but nobody of Norway within the team, but nevertheless 3 Scandinavians. So if you are making some guideline recommendation, it's always a very complicated and formal process. And I think what is important is that not only the specialties which are involved in the care of fibromyalgia patients, but although non-clinical scientists as well as patient representatives were involved into the recommendations. So the steering committee decided to focus on systematic reviews on pharmacological and non-pharmacological therapies in fibromyalgia. And what were the criteria to make a recommendation? There are several criteria. One was the efficacy of these treatments on pain, but also on fatigue, sleep problems, and daily functioning. How many trials were conducted, how many patients were assessed, how good was the quality of study and the quality of the review, and how was the effect size, let's say the magnitude of effect of the single treatments, but also what were the adverse events and what were the costs of the treatment. So, and if you make a strength of recommendation, it's based on the one hand on the potential benefits and on the one hand on the potential harms of a treatment, but also on the quality of the data, that is to say the confidence and the magnitude of the effect and the resource use. And then you can make some kind of the strengths of the recommendation. You can say it's strong 4. That is to say that the majority of the patients should receive this treatment, majority, not all. You can make a weak 4 recommendation, that is to say a lot of patients should receive this treatment. And you can make also a weakly against and a strongly against recommendation towards some treatments. So you can, it's all available online, free of cost. I just want you to give you impression how the evidence table looks like. You see here for some drugs like amitriptyline on the first line, and you see how many trials have been conducted and what was the dosage and was the quality. To make it short, some basic principle of cares you cannot base on randomized controlled trials, but only on consensus of experts and of patients. And these are the so-called overarching principles of care of fibromyalgia patients. First is it requires a prompt diagnosis. Second, it requires a comprehensive assessment. And again, it's not only pain, it's also daily functioning and the psychosocial context of the patients. It's also recognized in this EULAR recommendations that fibromyalgia is a heterogeneous condition. And this is very new, and I think it's very important that the management should take a graduated approach. I will talk about it later. So what are the aims of fibromyalgia management? And this is also very important, that it's not primarily to reduce pain, but it's to improve health-related quality of life and daily function. I think we can discuss it. And to achieve this goal, improvement of health-related quality of life, improvement of daily function, in most cases it needs a multidisciplinary approach, that is to say inclusion of medical doctors, psychologists, physiotherapists, occupational therapists, and a combination of non-pharmacological and pharmacological treatments which should be tailored. This is a third important topic to the individual symptoms of the patients, how much pain, how much sleep problems, how much fatigue, and also to psychological problems, and also important, what are the patient's preferences and comorbidities. So in Germany, there are some, complementary medicine is very popular, And I have some patients who say, oh, no, I do not want to take any synthetic drugs. I'm willing to take perhaps herbal medicine or homeopathy. I will not take any synthetic drugs. So this is patient preference. I accept it. So this is meant what its patient preferences. And the decision for treatment should be done by shared decision making of the patient with the doctor. That is, our task is to provide you to say, these are the treatment possibilities, these are the chances, and these are the risks, and what would you prefer? And again, shared decision making and initial management should focus on non-pharmacological therapies. These are the overarching principles. And now you see here the strength of recommendation for single treatments. And I think it's very important, and there was a big change towards the first EULAR recommendation, in which only drugs received a strong 4 and non-pharmacological treatments received weak 4 or sometimes a weak against. And this is a big change because the only treatment modality which received a strong 4 was aerobic or strengthening exercise. And you see also there was a strength of consensus, and the votes of the patient representative were equal to the notes to the votes of the medical doctors and psychologists, and there was 100% agreement for this strong 4. And other recommended therapies with a weak 4 are cognitive behavioral therapies, multi-component therapies, that is to say the combination of psychological therapies with any kind of exercise, defined physical therapies, that is to say acupuncture or hydrotherapy, and so-called meditative movement therapy as Qigong, yoga, Tai Chi, and mindfulness-based stress reduction. Again, you see that the strength of consent decreases with these non-pharmacological therapies. Frankly spoken, I was not much happy that cognitive behavioral therapies received only a weak 4 because the database is much better for cognitive behavioral therapies than for acupuncture or hydrotherapy. But that's how consensus processes are. There are also some majority votes. So drugs, there are only 6 drugs who received a positive recommendation. One was amitriptyline at low dose. Low dose is between 10 and 25, maximum 50 milligram %. Duloxetine or milnacipran, tramadol. And again, I wanted to stress, opiates are not recommended for fibromyalgia. Tramadol is something different because tramadol has also acts on noradrenergic receptors. So it's a little bit between opiate and serotonin noradrenergic reuptake inhibitor. And pregabalin and cyclobenzaprine. Cyclobenzaprine is a little bit similar to a tricyclic agent and has also sleep improving qualities. You probably, the doctors know that none of these drugs has been approved for fibromyalgia treatment in Europe. That's the European Medical Agency refused the approval of duloxetine, milnacipran, and pregabalin. They were right because the European studies were negative. Nevertheless, we can, even in Germany, we can prescribe these drugs in label because duloxetine, milnacipran, or pregabalin are approved for some mental disorders, depression and general anxiety disorder, which are frequently associated. I do not know how the situation in Norway if you have some problems with off-label use of drugs. So for us, it's a big topic. So there are also some negative recommendations with weak against. To start with non-pharmacological therapies, biofeedback, capsaicin, chiropractic, which is very popular in Germany, even also massage, S-adenosine, methionine, and guided imagery in homeopathy. All and homeopathy strong against. Why? The databases is not convincing. Most interestingly, in Germany, we have an open recommendation for homeopathy. You can see, depending with the same data, different guideline groups can come to different recommendations. So there are also some negative recommendations for pharmacological therapy, strong against growth hormone and strong opioids, the ones mentioned by Dan, like oxycodone or morphine. There are also some weak recommendations against monoamine oxidase inhibitors, NSAIDs, and sodium oxybate. Sodium oxybate works very well in fibromyalgia. Nevertheless, it was neither approved in the USA nor in Europe because of safety concerns. So you see, there are positive and negative recommendations are nearly equal in the EULAR recommendations. So this is now a slide which explains the graduated approach, how to treat patients with fibromyalgia. First, it all starts with the appropriate diagnosis. Okay, here. I do have a problem with this. Okay. The second step is adequate patient education and information sheets. So we'll show you the ones we use in Germany. So they are structured and based on our guideline. And then I said EULAR recommends to start fibromyalgia management with non-pharmacological therapies. And the first is individualized graded physical exercise. What is meant with individualized, I will tell you soon. And this can be combined with other recommended non-pharmacological therapies such as hydrotherapy and acupuncture. Why are these non-pharmacological therapy first recommended? I told you recommendations are based on the one hand on the efficacy of one treatment, on the other hand on potential risks. And these are the advantages of non-pharmacological therapies. The risks of serious adverse events are much lower for non-pharmacological therapies than for drugs. This was the reason of this decision of the EULAR. And if this does not work, this first step of non-pharmacological therapy, then reassessment of the patient should be conducted and tailored individualized treatment should be regarded. And tailored to what? Tailored to what the key symptoms of the patients. So if the pain is very high, then there's a recommendation to use either duloxetine, pregabalin, tramadol, or in combination with paracetamol. There's one study, positive study, each with tramadol and paracetamol in fibromyalgia pain. Again, some patients suffer more from sleep problems than from pain. And these drugs are known to promote sleep. It's amitriptyline, cyclobenzaprine, or pregabalin at night. If the main problem is in the psychological area, depression, anxiety, catastrophizing, then psychological therapies, including a mental health care specialist, and perhaps including some antidepressants for anxiety and depressive disorder are recommended. And I think we discussed it in the break. We have a lot of patients with fibromyalgia who are on long-term sick leave or applying for disability pension. And these patients should be treated with multimodal rehabilitation programs. And I think you in Norway and we in Germany are happy to have this multimodal rehabilitation programs in contrast to many other countries in the world. So this is what is meant with individualized treatment. And I will now come to some other guideline recommendations again with this graduated approach and why this staging of severity is important. I showed you in my first lecture that we can differentiate different forms of fibromyalgia, mild, moderate, and severe forms. And we should have to adapt our therapy to the intensity of fibromyalgia symptoms. I rarely see patients with mild form of fibromyalgia, but they are. They come along, they get along quite well in their daily life, and most of them, they have interesting jobs, they have a loving husband, and they have nice children. They have no big problem, and somehow they have adapted to their life. And they are physically and mentally active. And they ask me, could I do something more? And I say, no, go on, do it. Continue to be physically active and socially active. So for mostly, if you're working in a pain center, you see patients with moderate and in most form or severe forms of fibromyalgia. And I think aerobic exercise is one basic kind of therapy, and this does not only apply to any chronic pain syndrome, but it should be applied to lot of chronic internal diseases like hypertension, diabetes. But unfortunately, or not for drugs work better for hypertension, diabetes. Therefore, these people are not so much as forced to do regular aerobic exercise. But chronic pain patients, you know, drugs do not work in most patients as well as patients expect. And we know that aerobic exercise, regular movement, is one best thing we can do even if we are healthy. And therefore, it's recommended, and it always works in healthy patients as well in patients in chronic pain. So that is to say, aerobic exercise adapted to the individual level of fitness, and a temporary medication which we recommend in the Israeli and in the German guideline. And severe forms of fibromyalgia, people who are long-term disabled, these people in most cases, they do not have only fibromyalgia. Severity is driven by other functional somatic symptoms like IBS, and most importantly by mental comorbidities, in most cases by anxiety disorder, depression, or post-traumatic stress disorder. And these people need more. They need a multi-component approach, which includes pharmacological therapy and tailored therapy to the comorbid mental disorders. So, just to give you some of my ideas about tailored therapy. These are data of 300 consecutive patients in which I have diagnosed fibromyalgia. And before the first appointment, they are sent the German pain questionnaire, and they bring it filled out to the first appointment. And these are the average pain scores of the patients, and this is also what you see in clinical studies. Most patients score between 6 and 8 for average pain intensity, but you see they're all the patients with 9 and 10. And we know that the pain intensity is not only a measure of somatosensory pain, but it's very much influenced, especially in this high score, by anxiety, depression, and pain catastrophizing. So from a statistical point of view, 10% of the range of average pain intensity in these 300 patients can be explained by the sum score of the pain catastrophizing scale. So what do I mean with tailored treatment? So I said treatment starts with appropriate diagnosis and informing the patient what is the disease and what can treatment achieve and what is the role of the patient. And our German pain questionnaire also includes the questions: which pain intensity do you wish, or what must be achieved that you would say that the treatment is successful? And these are the scores, and you see that most patients, they wish that they have a mild pain, that is a pain below 3 and below. I can understand it. But if you look at the data of the studies, and if you look at your own data, you must be realistic. This is, if you see where these patients come from, if you make pain intensity as the major goal of your therapy and what they wish, this is more than 50%. And most studies, might it be with drugs or might it be with psychological therapies, you only get to a 50% and more pain relief in only a minority of patients. That is to say, one big point in patient education is to establish realistic treatment expectations. What can be reached regarding pain reductions, and can be other goals of therapy which are more appropriate than pain reduction. So I talked about information leaflets, and this is an information leaflet of the German League Against Rheumatism, fibromyalgia to start every day new. And we also have in Germany a quality center for any kind of disease, which produces this one-page leaflet for patients, and we are very proud that there's also a leaflet for fibromyalgia syndrome available, which is to say this is a recognized disease even for our Center of Quality in Medicine in Germany. Let's little more talk about drugs. I think this is what the medical system has talked to patients, and that what a lot of patients which come to me expect, that I will prescribe them a drug which will really help. Again, these are the data from the studies in which you see that only minority of patients will get a 50% and more pain relief. And the real world data with all of these drugs which had been labeled in which had been approved by the FDA, that is to say pregabalin, milnacipran and duloxetine, in real world data, the data are much more disappointing. You see, this is a study, that is to say you have high discontinuation rates. Patients stop the medication either because it does not work as they have expected, or because they have side effects. So the discontinuation rate in this US study was 65% for pregabalin and 52% for duloxetine and 72% for milnacipran after 12 months. And this is a recent study of Israel, and the 1-year discontinuation rates were even higher. And this is also what I see with my patients. So I see some patients who really profit from duloxetine or pregabalin, also in the long term, but most patients, they stop therapy to a certain time. And the idea to start in moderate forms of fibromyalgia with non-pharmacological and pharmacological therapies is that non-pharmacological therapies, they take a longer time before they work, before you can see a profit of cognitive behavioral therapy or of aerobic exercise. So with the drugs, it's within 2 weeks you can decide if it works or if it works not. So the idea is to have a start with drugs to relieve some symptoms and just to hope that the non-pharmacological therapies will work in the long term better and that you can reduce or stop the drugs. And again, I just want to warn to take, because pain is so intense in a lot of fibromyalgia patients, and suffering is so great that a lot of German and also US pain therapists that come from anesthesiology who are trained with the idea that they can titrate opiates and other drugs to pain intensity, that this is a wrong idea in fibromyalgia, because it does not improve the quality of life. In the contrary, it threatens the quality of life. And again, the aim of therapy is not to reduce intensity of pain, but to see if the life of the patient has improved. So, of course, I try to make some tailored therapy also with drugs, depending on the key symptoms of the patients. So I use amitriptyline or pregabalin in case of sleep disturbances. I use duloxetine or milnacipran for depression, and perhaps there are some small studies also duloxetine or pregabalin can reduce some symptoms of post-traumatic stress disorder. And duloxetine and pregabalin are approved for generalized anxiety disorder in most European countries. But again, you have to consider also the internal comorbidities of the patients. If the patient has a rather severe liver disease, you should not prescribe SNRIs. And in Germany, you cannot be a professional driver if you are on a pregabalin. Bus driver, not possible. And I think this is a very important topic. It's our patients' preferences. So weight gain is a problem with women between 40 and 60, and especially if they're in chronic pain. And if they do not want at all to gain weight, then I would not start a therapy with amitriptyline or pregabalin because it's a very frequent side effect. So, tailored exercise, again, what are the criteria? One criterion is patient preferences. Of course, a standard aerobic exercise is walking or jogging or cycling, but there are some patients who do not like it, and but perhaps they like dancing. And there are also two studies which show that dancing can also improve fatigue. Another topic is local availability. And a most important topic to me is medical comorbidities, especially patients with osteoarthritis of the hip or of the knee, or patients who are obese. They have the risk that the pain in the lower extremities will increase if they do walking or jogging. Therefore, the aerobic exercise, which is most appropriate for a lot of patients, especially if they have osteoarthritis or obese, is aquatic exercise, especially if the water is warm. I do not know if they have a problem in Norway with the temperature in the water in the swimming halls. So in Germany we reduce cost, and we have normally in the past had some warm water swimming days with temperature between 30 and 32 degrees. This was very agreeable for fibromyalgia patients, but if the temperature is between 25 and 28 degrees, so they are shivering, and aquatic exercise will not work so well. So what we have achieved by our German guidelines is that there's a special kind of combined land-based and water-based aerobic exercise, especially designed for fibromyalgia patients, only for them, and which is paid for by our German health insurance companies for 2 years and longer. And this is not counted into the financial budget of the doctor who is prescribing it. So this is what I mean with tailored exercise. And this is our regional approach from the federal state I'm living. So we have some fibromyalgia groups, and they have founded a network. And this network, we have also a special internet address. And this network provides quality-proofed information, what is fibromyalgia, and there's also a patient version of our German guideline. And there is a very important page on this internet page, is what you can do by yourself. Was Sie selbst tun können. And here we have the links to the local offers where you can go for aquatic exercise. Where are the special training groups for fibromyalgia patients? Where are these other groups who offer some kind of walking, aquatic exercise, tai chi, yoga? And that is to say, we try to collect the information for the patients, but they have to check the internet by themselves and have to apply for the group by themselves. And but they can be supported by the self-help groups. And we have also a list of some therapists, let's say rheumatologists, pain therapists, psychologists, physiotherapists, who say, okay, I treat patients with fibromyalgia. Interestingly, it was very difficult to convince our regional rheumatologist to be taken into this list. And most of them accepted, but they only for diagnosis, not for management. I do not know how the situation is with Norwegian rheumatologists. How do they accept fibromyalgia patients? But we have some pain therapists who are willing to treat fibromyalgia patients. So lastly, I want to talk about tailored psychotherapy. We talked about different subgroups of fibromyalgia, and there's a rather large subgroup with mental disorders. And in this patient, there's a lot of emotional pain and fibromyalgia. And this is perhaps a point, Dan, we do not agree. I think there's some evidence that these childhood adversities, daily hassles, and stress will also contribute to the central sensitization process. So this is something which can develop during your life if you have some genetic kind of sensitivity to it. So there's a subgroup with this high impact of emotional pain into this high pain intensity. And in this patient, the aim of therapy cannot be to reduce the pain, but the goals of therapy are to improve meaningful action of the patient despite the pain intensity. And as Forder, who was a psychologist, he said, people have something better to do, who have something to do for meaningful action, do not suffer as much as people who do not have meaningful action. Therefore, we have some other goals of therapy if it goes to psychotherapy in fibromyalgia patients. So one also outcome and study is pain acceptance. And another outcome for me in my therapy is satisfaction with your life, irrespectively if you have pain or not. And if it comes to improvement of individual functioning, so for me, I make individual goals for the patient. What does he want, she want to achieve concretely in life? Itchy for work in the garden, itchy in social leisure times. What is the aim? And then we can check if we start any kind of therapy, if this individual aim can be achieved. And this is something different than we do in studies. And one, to me, very, very important therapy for chronic pain patients in general and for fibromyalgia patients in special is ACT, acceptance, and commitment therapy, because this kind of therapy can help the patient to find out what is really important in their life, what are their values, and which meaningful action they want to pursue in the future with their pain. So, and again, I want to show that this acceptance-based cognitive behavioral therapies, which include ACT therapies, really work better than the traditional cognitive behavioral therapies. This is a very recent systematic review I've conducted with a psychologist, and which is published in the European Journal of Pain. And here you see the effect size of the acceptance-based cognitive behavioral therapies with ACT therapies, and these are the one of traditional cognitive behavioral therapy. On this outcome improvement, at least of 20% of health improvement of health-related quality of life. And this is another term why, another reason why EULAR ranked psychological therapies a little bit higher than drug therapies. Drug therapies, if the major aim of therapy is to improve daily functioning and quality of life, then we have to look at the data. And you see that with drug therapy, here self-reported disability as an endpoint. You see duloxetine, it has an effect size which you can say is clinically relevant. Milnacipran, this effect size is not clinically relevant. And even the effect size of pregabalin on disability includes 0. That is to say, it's not statistically significant. I will not say that no patient with fibromyalgia will profit from pregabalin regarding disability, but the average patients and the data say the majority do not. In contrast, if you see psychological therapies, they work in the long term, and they work also if the therapy is stopped. These are data at 6 months follow-up after the end of therapy of cognitive behavioral therapies, and you see you have here a moderate effect size on the reduction of disability. That is to say, psychological therapy is more harder, takes more time, takes more energy, but in the long term it works better than drugs. So One last slide, according to tailored psychotherapy. My personal opinion is that traditional cognitive behavioral therapy are a good basement for pain therapy, but we have to tailor our psychological therapy much more to the patient. That is to say, patient with depressive disorder, they need another additional kind of psychotherapy, for example, interpersonal therapy. And there are some patients with fibromyalgia with post-traumatic stress disorder, and although for this kind of psychological disorder, we have special kind of therapies like eye movement, desensitization, and restructuring. And also hypnotherapy can be very useful in this patient with PTSD. And for this subgroup of patients with childhood adversities and major life events affecting their emotional pain, there are new therapies. Dan, your group conducted this very well conducted study with emotional awareness and expression therapy. And also EMDR can be used for this childhood adversities. And there's also a very good study with forgiveness interventions. So patients with chronic pain, fibromyalgia, some of them really suffered emotional pain and humiliations, and people did them wrong. And sometimes this cannot be changed. And even these people who hurt it, the pain patients might have died, though there's no chance to go into a direct confrontation with it. And for these patients, something with forgiveness, with an imagination, can help to reconciliate with their biography. So I want to summarize the updated EURA recommendations. Recommend approach. This is graduated. You start with non-pharmacological therapy and you go on depending if the patient responds. And it's tailored to the key symptoms: pain, fatigue, sleep problems, psychological problems. And I want to encourage you to also consider with your individual patients tailored therapy. That is to say, to tailor the exercise you recommend to the preferences of the patients and his internal and orthopedic comorbidities, and as well the drugs to the main symptoms and the psychological therapies to the mental comorbidities. Thank you.